Thank you, Dr. Rajesh. We have two presenters who are young and dynamic. They took up the challenge. They are about to present. We wish you all the best for the first year PGs. I call upon the Dr. G. Priyanka, give her presentation. Please share your presentation and proceed. Dr. Priyanka, take up.
Sir, is my screen visible, sir?
Yes.
Yes.
Yeah, am I audible, sir?
Yes.
Yes. Yeah. Okay. A very good evening to each and everyone. Thank you for giving in this opportunity for presenting this case. I'm proceeding with the case presentation. A 19-year-old crimey with gestational age of 33 weeks and 5 days was referred from obstetrics and gynecology department. She was referred with chief complaints of sudden diminution of vision in both eyes since 1 day. History of present illness. On post-operative day 1, she underwent cesarean section. She came with complaints of diminution of vision in both eyes, which was sudden in onset, painless in nature since 1 day, and she describes as curtain falling over field of vision. There are no other complaints of any pain or redness, and no complaints of floaters, flashes of light, and there is no history of any ocular surgery, and there is no history of any usage of glasses, and there is no history of trauma, and no history of lifting heavy weights, and no history of significant fever, weight loss, and cough. Past history. There is no significant past ocular history, and there is no similar kind of illnesses in the past. As per her history, she conceived spontaneously, and her first and second trimester of pregnancy was uneventful. And at 33 weeks, 5 days of gestational age, she presented with complaints of bleeding per vaginum, and high blood pressure recordings were also noted, which were of about 160 by 100 millimeters of mercury. Expected management was done for preeclampsia with oral antihypertensives for about 1 week. The oral antihypertensives which were given for her was tablet labetalol 100 mg twice a day and tablet nifedipine 10 mg BD. After 1 week, patient had imminent symptoms. The patient her blood pressures were controlled throughout the week with oral antihypertensives. But later, after 1 week, the patient had imminent symptoms with high blood pressure recordings again. And then she was started on Maxelf regimen, and induction was also done simultaneously. Fetal heart sounds were normal, and they planned for cesarean section. But suddenly, patient landed into abruptio placenta with intrauterine death, which was confirmed by absence of fetal sounds, and emergency cesarean section was done in view of failed induction with intrauterine death. On post-operative day 1, she presented with above complaints as we have seen before. No history of any systemic diseases like hypertension, diabetes, bronchial asthma, epilepsy. Moving on to the family history, there is no history of any similar illness in the family, and there is no history of any consanguinity, and there is no history of ocular diseases like glaucoma, night blindness, and there is no history of systemic diseases including diabetes mellitus, hypertension, bronchial asthma. Moving on to the treatment history, this is in the chronological order. She was on tablet labetalol 100 mg twice a day and a tablet nifedipine 10 mg for the first one week where her blood pressures were controlled. Later on, when she had sudden imminent symptoms and rise of blood pressure of about 160 by 100, she was on injection Maxelf, which is Pritchard's regimen. A loading dose and maintenance dose was given. And along with this, injection labetalol 20 mg IV stat dose was also given, and later on she was on with this treatment of IV treatment. Moving on to the personal history, she takes mixed diet, her appetite is normal, and sleep was undisturbed, and bowel and bladder habits were unaltered. And clinical examination, moving on to the general examination, she is conscious, coherent, oriented to time, place, and person. She is moderately built and nourished. On examination, she had mild pallor with pedal edema, and there is no signs of any icterus, cyanosis, and clubbing. Vitals at the time of examination, her pulse rate was 84 beats per minute, which was equal on both sides and regular in rhythm, normal in character, no thickening of vessels noted. And blood pressure at the time of examination was 160 by 100 millimeters of mercury, which was seen in left supine position. And respiratory rate was 16 breaths per minute, and she was afebrile. And systemic examination. In systemic examination, cardiovascular system S1, S2 were heard. Respiratory system, bilateral air entry present. In abdomen, dressed caesarean section wound was present. In CNS, all higher intellectual functions were normal and cranial nerves appears to be normal. Now moving on to the ocular examination, head posture is midline, facial symmetry was
1 minute. 1 minute. Will you stop there? Was the defective vision bilateral or unilateral?
Ma'am, both eyes, ma'am.
Both eyes. What
Yes,
are the
ma'am.
conditions where you get bilateral visual fall in a pregnant lady?
Ma'am, sudden onset vision loss can be seen in different conditions, ma'am. In uniocular conditions, it may be due to the retinal detachment and CRAVO and CRVO and vitreous hemorrhage. And in case
She
of
is a
bilateral,
pregnant lady, postpartum.
yes, ma'am.
Bilateral. What are the
Yes,
causes
ma'am.
you suspect?
Here in this case, as it was sudden rise of blood pressure is seen, it mostly favors over the retinal pathologies, ma'am. Can be associated.
Any final years are there who have joined you?
Ma'am, even in pituitary
Madam,
apoplexy, Sheehan syndrome variant also, there may be chance. Cortical blindness may occur, ma'am.
Yes.
if anybody
Any
is
other
having
thing?
two screens, please close one screen. If anybody is having two screens, or if anybody is having a TV running in the room, please close that.
Okay, proceed. Proceed.
Okay, ma'am. Moving on to the ocular examination, head posture was midline, and facial symmetry it was bilaterally symmetrical, and extraocular movements they were free, full, and painless in all gazes. Moving on to the examination of right eye. In right eye, uncorrected visual acuity was counting fingers 2 meters, and there was no further improvement with pinhole, and she was able to identify the primary colors, ma'am. In right eye, orbital margin appears to be intact. Globe was orthophoric in position. Eyebrows were normal. Eyelids
You
were
skip
normal.
all the normal findings. You tell only the abnormal.
Okay, ma'am.
Everything is
Intraocular,
normal.
everything is normal here up to the examination of right. In left eye also it was normal, ma'am. Intraocular pressure, which was measured by Goldman's apprenticeship tonometer at 11 a.m. was 12 mercury in right eye and 14 millimeters of mercury in left eye, ma'am. No other any significant findings here.
Stop. You said the pupillary reaction is normal,
Yes,
right?
ma'am.
Both
Yes,
eyes. But the
yes, ma'am.
vision is only counting fingers and hand movements, is it not?
Yes, ma'am. Yes,
What
ma'am.
are the causes which produce? When the pupillary reaction is normal and a gross fall of vision, what are the conditions you suspect?
Ma'am, if any macular involvement is there, then there will be vision loss will be more significant, ma'am.
No,
Uh,
no.
uh,
Mm,
oh,
One condition you should suspect in this case is a cortical blindness.
okay,
One
ma'am.
of the things. Okay?
Okay.
First
Okay,
thing,
ma'am.
because she is a pregnant lady, you are talking.
Yeah, ma'am.
One of the conditions you should suspect here is
Cortical blindness.
Okay.
Okay,
Right.
ma'am.
Come on, proceed. Other things you have to tell me later.
Okay.
Right. Come on, proceed. Proceed.
Uh, Moving on to the fundus examination, which was done with slit lamp 90 diopter lens, and also with indirect ophthalmoscopy. In right eye fundus examination, it was clear media with red glow. Optic disc size and shape is normal. Cup-disc ratio is 0.3:1. Neuroretinal rim looks healthy. Vessel ratio was 1:3. An arteriolar narrowing is seen. Macula foveolar reflex is altered. An elevation of 2 disc diameters present at the macula. Periphery appears to be normal. In left eye fundus examination, media was clear. Optic disc is normal in size and shape. Cup disc ratio is 0.3:1. Neuroretinal rim look healthy. Vessel ratio is 1:3. Arteriolar narrowing seen. In macula, foveolar reflex altered. Background retina shows undulated folds over the superotemporal quadrant, which were extending up to the macula. And periphery appears to be normal. These were the fundus pictures. This is the fundus picture of right eye, and this is the fundus picture of left eye. Here we can see the superotemporal detachment and with the narrowing. This is the B scan. This is
Go
a B
back,
scan of
please. Go back a little. That. So I say this is a choroidal detachment.
choroidal
I say
detachment.
this is a choroidal detachment.
Mm.
Clinically, when you see
Ma'am.
fundus,
Yes.
how do you differentiate a retinal and a choroidal detachment?
I mean, retinal detachment.
Right, come on, proceed. You have to write the answers.
Yes,
Whatever questions are asked, make a note of it and write the answers. Right.
Okay, ma'am.
Oh, 10. Proceed.
This is the B scan of right eye and left eye. In B scan of right eye, general and orbit mode, lens occurs in plane, optic nerve head is normal, vitreous shows few low reflective dot echoes. In left eye, it is general and orbit mode, sitting and supine position, lens echoes were in place, optic nerve head is normal, vitreous shows a high reflective membrane echo with limited after movements noted, shifting fluid sign present. This is the OCT, ma'am. In OCT, it is a macular cube scan SD OCT of both eyes with foveal contour maintained with central thickness of right eye is 682 micrometer and left eye is 835 micrometer. Both eyes OCT shows intraretinal fluid and subretinal fluid with submacular detachment, left eye more than right eye.
How can the foveal contour be normal or maintained when you have a subretinal fluid in the macular area and the foveal area? You said there is an elevation of in the macular area, the fovea of 2 diameters. How can the foveal contour be normal? It cannot be normal, is it?
Okay, ma'am.
Even on OCT, it cannot be normal. What you are showing in OCT, it shows a subretinal fluid there.
Okay,
and the
ma'am.
contour is not maintained. You are seeing multiple cysts there. Cystic spaces
Yes.
are there, and an RPE
Okay.
detachment also you are seeing.
Okay, ma'am.
Okay, now proceed.
Systemic investigations. There was proteinuria of 3 plus with urine dipstick and renal function tests were normal. Liver function test and coagulation profile was normal. Further, on post-operative day 4.
Go back. Why did they do the coagulation profile and liver function tests in this case?
Ma'am, in this case, they want to rule out the HELP syndrome, which is hemolysis, which is
I know.
associated with preeclampsia,
Okay.
hemolysis and elevated liver enzymes and low platelet count. To rule out all those things, they did the liver function test and coagulation profile. But in this case, there was only low platelet count, and there is no elevated total bilirubin, ma'am. So they kept as partial HELP. It was not a complete HELP syndrome. They kept in that way, ma'am, diagnosis.
Okay. Come on, proceed.
On post-operative day 4, her visual acuity improved in right eye 6.9, with pinhole it is improving to 6.6, and in left eye it is 6.6. And further on post-operative day 6, her visual acuity of right eye is 6.6 and left eye is 6.6 partial. These were the further pictures which were taken on post-operative day 4, right eye and left eye, where we can see the cell resolution of the RD. These were the B scan pictures, ma'am. This is the OCT.
Now the foveal contour is now.
Okay, ma'am. Okay, ma'am. Done.
Okay?
Okay,
Right.
ma'am.
Not previously.
Okay, ma'am. Case summary, 19-year-old primey with preeclampsia presented with complaints of sudden painless diminution of vision in both eyes with curtain falling over field of vision. And probable diagnosis is bilateral serous retinal detachments, which is possibly secondary to preeclampsia. There was spontaneous resolution of retinal detachment by controlling the blood pressure.
Okay. You said there is a spasm of the narrowing of the arteries, vessels, is it not? Fundus.
Yes,
Retinal,
ma'am.
yeah.
Yes, ma'am.
What is the cause for this spasm?
Ma'am, due to the sudden increase in blood pressure, there will be due to autoregulatory mechanisms, there will be vasospasm, ma'am. Diffuse arteriolar narrowing will be seen in acute cases of sudden rise in hypertension.
Suppose this hypertension continues for a longer period of time. What are the changes you see in the vessel wall?
Ma'am, AV crossing changes will be seen, ma'am, and further on sclerotic changes will
You take
also
a
be seen.
section of the vessel. You take a
Okay.
section of the vessel. What are the
Ma'am.
changes you see in the vessel?
In the section of the vessel, there will be intimal layer thickening, ma'am. Intimal layer thickening will be seen, and muscularis layer also. There will be hyperplasia of the muscularis layer. And endothelial damage will also be seen, ma'am, which is the main basis for the RD, where the outer retinal barrier will be further damaged, which leads to the serous RD.
Dr. Priyanka, please stop sharing. Please stop sharing. Stop sharing.
Yeah, sir, I'm just stopping.
Yeah. Now we can continue with the discussion.
Yes. You even
And
see hyalinization of the vessel, is it
yeah,
not?
ma'am. Yes, ma'am. Yes, ma'am. In further cases, there will be damage to the endothelial cells, which leads to the damage of outer retinal barrier, which leads to the loss of function of retinal pigment epithelial cells, which forms the basis for serous RD.
Is serous detachment common in pregnancy, preeclampsia?
No, ma'am. Only as per the records and as per the journals available, only in 2% of preeclampsia patients we see this spontaneous to see this serous RD, ma'am, which was usually resolved spontaneously after controlling of blood pressure.
How frequent is it in normal accelerated hypertension patients, leave alone pregnancy?
Ma'am, it was it's like around 2% they gave in that manner.
No, not the pregnant woman, not preeclampsia. A normal person presenting with accelerated hypertension.
Okay.
What is the percentage? How frequently do you see a SRT?
I'm not sure about that, ma'am. I'll refer that, ma'am.
And why is it common in preeclampsia?
In preeclampsia, as blood pressure will be elevated out.
Accelerated also, it is increased. What is the role of placenta here?
Yes, ma'am. Placenta, HCGs, fetoprotein, like all HCG gonadotropins also play a role in elevating the blood pressure. So that's the reason I got it, ma'am.
Right?
Yes, ma'am. Yes, ma'am. Yes.
What is the role of spiral arteries here? Uterine spiral arteries and the blood pressure control.
Spiral arteries.
And that is where the placenta plays a role, is it not?
Yes, ma'am.
So there will be release of what? When there is a placental disruption, dysregulation is there will be release of?
HCG will be released.
What else?
Placental growth factors.
Placental growth factors are not released. That is why you are going to have the damage to the endothelial vessels.
Okay, ma'am.
Right, good presentation. What else do you get? What else can you get in a patient with preeclampsia and a hypertension? What are the other changes you can see?
From anterior segment, from when
No, only retina. We'll talk only of the retina.
Okay, ma'am.
Choroidal changes, what you see?
Choroidal ischemia will be ischemia will be there, ma'am.
Yes. What are Elschnig spots?
Elschnig spots in sudden acute rise of blood pressure due to the fibrinoid necrosis in the retina. A black color spot will be seen, ma'am. Surrounding that black spot, a yellow color lesion will be deposited. It is termed as Elschnig spots, which is seen in young individuals with abrupt rise of blood pressure.
What will be the differential diagnosis? Suppose you don't know the patient is a hypertensive. What will be the differential diagnosis for that? A pigmented lesion with a surrounding hypopigmented. What is the differential diagnosis you think of? Okay, Fine. You
Left
read
from
about that.
Yeah.
And hypertensive retinopathy, what optic nerve head changes do you get? What are the optic nerve lesions you can get? Accelerated hypertension or preeclampsia? What do you get?
Due to the hypertension, optic nerve may also be associated. It is termed as hypertensive optic neuropathy. In hypertensive optic neuropathy, when it is getting progressed, there will be papilledema features will also be seen, ma'am. In late stages, papilledema findings will be seen, where blurring of disc margins will be seen. And in splinter hemorrhages may also be seen in some cases.
Okay. And what are the macular changes you get? If suppose this fluid is not resolved, what
Yes,
macular changes can you get?
macular edema will subside
Yes.
for long duration, and macular star may also be seen, ma'am.
Suppose you see a macular scar later in life, what will be your differential diagnosis for that?
Ma'am, can I get your question again? Macular star.
Suppose you see a macular scar later in life.
Okay, ma'am.
This patient had a edema which has not resolved for a long period of time. You
Yes,
see a
ma'am.
macular scar. What will be the differential diagnosis?
Retinitis, chorioretinitis. I'll see that, ma'am. I'm not sure.
Right. Why is the fluid accumulating only in the macular area?
Macular hole.
Macular area, you are seeing a fluid, is it not? Why is the macula more prone for fluid accumulation?
Ma'am, some of the layers were absent in macular region, like inner nuclear and inner plexiform, and ganglion cell layer.
Okay, right. Good presentation.
Thank you, ma'am. Thank you.
Rajesh, Dr. Danya is there?
Yeah, I am here, sir. I'll
Madam,
yeah,
any more questions?
Yeah, sure. Dr. Priyanka, it's a very good presentation. Yeah. Now, can you just explain to me the pathogenesis of this serous macular detachment you have seen here?
Yeah, ma'am, sure. Ma'am, due to the rise in blood pressure, there will be vasoconstriction. It further leads to the choroidal ischemia, as the choriocapillaries will supply the outer blood retinal outer 4 layers of retina. Here, due to the choroidal ischemia, there will be vascular compromise, and there will be disruption of function of RPE, which is the RPE retinal pigment epithelial cells, which prevent the accumulation of the fluid in subretinal space. But here, due to the vascular compromise, the RPE function will be lost, which is nothing but the outer retinal barrier will be seen. So the fluid will be accumulated in the subretinal space, and later on in this case it even extended to intraretinal. So we are seeing here multiple subretinal and intraretinal fluids, ma'am, in this case.
Good. And how about your picture, what you have shown here, the left eye, you have showed me a superior RD, right?
Yes, ma'am.
Normally, exudative RDs are always in the dependent position.
Okay, ma'am.
And you said it's a shifting fluid. You have taken a fundus photo in the sitting position. Why is the RD superior?
Superior temporal is the
If you have made the patient sit for some time, if it is an exudative fluid, it has to come down. It will always be inferior when you are taking a fundus pick, right? But you have shown me a superior or superior temporal fluid. Any particular reason for that?
that layer is the protein.
It is protein rich, protein rich, but maybe it is a localized CSR at a point. Okay. Say exudative RD, and when it is bullous exudative RD, it tends to come inferiorly. But if it is RD, like a central serous retinopathy or a serous retinopathy which is developed in one particular area, it can be localized to that part. Maybe the part where you have a choroidal ischemia, and that is the part you have developed a RPE barrier disruption and has developed that. Okay. Good. And you have mentioned in your history this was a spontaneous conception. Any particular importance for that word, a spontaneous conception?
I don't know.
Okay, so if this lady would have gone for an IVF treatment or any particular medications, can those cause any other problems? You can see majority of these IVF women going for preterm deliveries. Okay. And mentioned the subruptio placentae. All these are higher patients who are undergone.
They'll be more prone for preterm delivery. So it is okay, ma'am.
So here it is a 19-year-old and a spontaneous conception.
Yes,
And
ma'am.
here there is an intrauterine death. Okay.
Yes.
So your pathogenesis, what you have so far mentioned in a serous macular detachment, as you said, the hypertension and then choroidal ischemia, that is one pathway.
Okay, ma'am.
Another pathway which got accelerated here. There is an intrauterine death which happened. So what
Yeah.
would have been released into the bloodstream?
చెప్పండి మ్యామ్. ఇంట్రాయూట్రైన్ డెత్ వల్ల ఏమి బాడీలో రిలీజ్ అయి ఉంటుంది?
What about,
Cytokines, prostaglandins.
what about DIC? Heard about DIC?
Yes, ma'am.
So DIC is one component here which would have caused this problem. Is a disseminated intravascular coagulation, particularly neoplasm, which gets released from the placenta, would start an extrinsic cascade of coagulation, which would have caused the similar pathology. Like the two pathways, what you have explained is one pathogenesis, the other pathogenesis, the pathway of coagulation cascade, which particularly might have happened in this woman because there is an intrauterine death. Okay, so you should also keep in mind DIC, which can cause fibrinoid necrosis within the capillaries. So that also led to this serous macular detachment.
122620, please mute.
Mute.
Who is this 122620? Please mute. And I don't think you are a faculty. Please log out. Excellent presentation, Dr. Priyanka.
Thank you, sir. Thank you so much.
I think I should congratulate not you. I should congratulate Dr. Sadhana, Dr. Sirisha, and Dr. Ravibabu garu. This shows the quality of the teaching. I mean, the quality of the work that is going on there in Guntur Medical College, Guntur. Congratulations, Dr. Ravibabu garu.
Thank you, Dr. Rajesh.
So, madam, anything else you want to ask to Dr. Priyanka, or can we go to the next case?
I think we can go to the next case.
We'll go, Rama. Danya?
Yes, sir. We can go.
Okay. Thank you, Priyanka. We'll move on to next case. Preeti.
Thank you, sir.
Preeti?
Thank you for
Okay.
giving me this opportunity.
Preeti?
Good evening, sir.
Okay, take up and give your
Yes, sir.
presentation.
Yes, sir.
Please share your screen.
Good evening, respected sirs and ma'ams. Thank you for the opportunity for presenting the case. I'm Dr. Preeti, studying first year postgraduate in GVP Medical College, Vizag. So can I start the presentation, sir?
Yes, Amma. Go ahead.
This is a 38-year-old male patient named Durga Prasad who is residing in Tagarapalsa. He came with a chief complaint of defective vision in both eyes, associated with headaches since 10 days, and complaints of double vision since 10 days, and complaints of the deviation of the left eye towards nose since 10 days. And there were no history of pain. There was no history of fever or neck pain. There was no history of diurnal variation. There was no history of earache or hearing loss. There was no history of facial pain or numbness. There was no history of weakness of upper and lower limbs. There was no history of trauma or cranial surgeries. And there was no history of drooping of eyelids. Coming to the past history, there were no similar complaints in the past. He's not a known diabetic or hypertensive. He doesn't have a history of thyroid eye disease. Coming to family history, there was no significant family history. Personal history, the patient takes mixed diet. He is a not known smoker or alcoholic. The bowel and bladder habits were normal. Coming to the general examination, patient was conscious and coherent, moderately built and nourished. There was no pala, icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema. The vitals temperature was he was febrile and the pulse rate was 82, but the blood pressure was 170 by 100. Coming to systemic examination, the CVS, the S1 and S2 had heard there were no murmurs. Respiratory, normal vesicular breath sounds were heard. The parabdomen was soft and no organomegaly was seen. Coming to the examination of CNS and PNS, sensory system, the pain, temperature, touch, and stereognosis were normal. Motor system, the tone and power were normal. Cerebellar functions were intact. The superficial reflexes and deep tendon reflexes were normal. Coming to the local examination, the head posture, there was slight face turn towards the left side, and the facial symmetry was maintained, and the eyebrows and eyelids were normal. Coming to the extraocular movements, they were free and full in all gazes in the right eye, and they were restricted in the left gaze. That is -3 restriction in the levo version, and -2 restriction in the levo elevation, and -2 restriction in the levo depression. And the palpebral fissure height was same in all gazes. Coming to dextroversion, levoversion, dextrodepression, levodepression, dextroelevation, and levoelevation, they were all normal in the right eye. In the left eye, they were restricted. Levoversion -3, levodepression -2, and levoelevation was restricted of -2. These were the 9 cardinal gauges. This is the primary position of the patient. This is the elevation. This picture shows depression. This picture shows dextroversion. This shows levo version, which shows -3 restriction in the left eye. This is levo elevation. This also shows restriction in the left eye. This shows levo depression. This also shows restriction in the left eye. This is dextro elevation image, and this is the image of dextro depression. The visual field by confrontation test was normal. These are the anterior segment of the right eye and the left eye. Coming to the right eye, the best corrected visual acuity was 6.9 with +1 spherical correction, it improved to 6.6. And the near vision was N6. And the eyelids were normal. Palpebral fissure height was 11 mm. Conjunctiva was normal. The cornea was clear. And the sensations were present. Anterior chamber depth VH of 4. Iris was of normal color and pattern. The pupil was of 2 mm reacting to light. Both the direct and indirect light reflex were present. Coming to the left, lens status, both eyes, the lens status was clear. The left eye, the best corrected visual acuity was 6.9. And with correction of +5 spherical and +5 cylinder in the -N30 axis, it improved to 6.6 vision. And then near vision also was N6. Eyelids were normal. Palpebral fissure height was 11 mm. The conjunctiva was normal and the cornea was clear. And there were sensations present. The anterior chain depth was VH of 4, grade 4. Iris was of normal color and pattern. The pupil was 2 mm reacting to light. The direct light reflex and indirect light reflex were present. The lens status was clear of both eyes. The intraocular pressure measured by Goldman's applanation tonometer was 14 mm Hg in both eyes. Coming to the fundus examination, the right eye, the media was clear. Optic disc size, shape, color margins were normal. The vertical cup disc ratio was 0.3:1. And the NRR is healthy and follows ISNT rule. And the vessels on disc and elsewhere were normal. The FR was absent. Coming to the left eye, the media was clear. Optic disc size, shape, color margins are normal. The vertical cup disc ratio is 0.3:1. NRR is healthy and follows ISNT rule. The vessels on the disc and elsewhere were normal. And the macula FR is dull or absent. Coming to the Hirschberg's corneal reflex test, the reflex shifted temporally and present between the pupillary margin and the limbus, which is suggestive of 30 degrees of ESO deviation. Coming to the prism bar test, it shows deviation of 18 prism diopters on left lateral gaze, 16 prism diopters on left levo elevation, 17 prism diopters on levo depression. Coming to the force generation test was absent and the force duction test was negative. Coming to Worthford dot test, 2 red and 3 green was seen. Red was seen on the right and green was seen on the left. The 5 dots were seen, which was suggestive of diplopia. Coming to the diplopia charting, there was a horizontal separation seen in the left side, more in the left gaze, suggestive of vertical diplopia, horizontal diplopia in the left gaze. Maddox rotus points or slight seen right to the red streak of light, which is suggestive of uncrossed diplopia. Coming to the cranial nerves examination, all the cranial nerves except the left abducens nerve was abnormal. The rest all cranial nerves examination was normal. Coming to the summary, it is a 38-year-old male with defective vision, and complaints of double vision and deviation of the left eye inwards towards nose since 10 days. Patient was having BP of 170/100, and he was having restricted lever version, lever elevation, and lever depression movements with prism bar cover test showing deviation of 18 diopters, 16 diopters, and 17 prism diopters on lever version, lever elevation, and lever depression respectively. And the diplopia was seen on Worth dot test. And on Hirschberg's corneal reflex test, 30 degrees of ESO deviation was seen. And there was a negative force reduction and absent force generation test seen in the patient. The provisional diagnosis is incomplete acute left eye 6-nerve palsy, which is most probably at the infranuclear level, which is most probably secondary to hypertension or the de novo hypertension or de novo diabetes. Ma'am, shall I continue with the investigation?
Not necessary. Madam? Sandhya madam?
Yes, sir. Yes.
Madam, we'll proceed.
Continue, ma'am. Continue. We'll see. Okay.
The patient was referred to neurology and the MRI brain was done, and it showed the following impression. It shows the diffuse dural meningeal thickening with increased post-contrast enhancement along the tentorium cerebelli, bilateral temporoparieto-occipital regions. There was irregular meningeal urine thickening with increased post-contrast enhancement along the left cavernous sinus, extending into the inferior orbital fissure. And there was probable enhancement of the left 6 cranial nerves along the cavernous sinus. Features were likely sequelae of meningitis or granulomatous etiology was to be considered. The patient had a HbA1c of 7.75, but he's not a known diabetic. And the BP was 170/100. He's not even a known hypertensive. So most probably these are the secondary to hypertension or diabetes. Thank you.
Right. What is the duration?
10 days. According to the patient, he only said it was 10 days.
Was there any history of fever?
Ma'am?
History of fever?
No, ma'am. No history of seizures.
No history of
fever. No, ma'am.
No history of fever. Right.
Yes, ma'am.
What do you think is the cause? The cause you have told is hypertension.
Hypertension or diabetes, secondary to microvascular changes due to hypertension or diabetes.
What is the primary deviation in this case?
Primary deviation, ma'am.
Yeah. You have mentioned everything. Primary deviation.
Yes.
What is the secondary deviation? You can go back and
Secondary deviation.
primary and secondary deviation. You are saying this is a paralysis, is it not? In a
Yes, ma'am.
paralytic squint, you have to look for the primary and a secondary deviation. And what do you mean by primary deviation?
I'm
Dr.
not
Preeti?
exact.
Dr.
Yes.
Preeti,
Someone
stop
can
sharing.
answer.
Stop sharing.
Tell me the
Yes.
primary definition of primary deviation. Primary deviation ఎప్పుడు అంటాం?
Any of the PGs who are here.
What is primary deviation? What is secondary deviation?
Deviation in the squinting eye is primary deviation, sir, when normal eye is fixating.
Yes.
The secondary deviation is the deviation in the normal eye under the cover when the squint eye is told to fix
Okay.
it.
What will be there in a paralytic squint?
In paralytic squint, the secondary deviation is more than the primary deviation.
Why? It is
Due
gone
to
by
the
which law? It is gone by which law?
ma'am?
It is governed by which law? Which law is responsible for this secondary deviation more than primary?
Law of equal innervation, ma'am, to the yoke muscles.
Herring's law.
Herring's law of equal innervation to the
Okay.
yoke muscles.
Herring's law of equal innervation responsible for this secondary deviation more than primary.
Law of equal innervation, ma'am, to the
Yes.
yoke muscles.
And here, the lateral
Herring's law.
rectus is involved.
Herring's law
What
of
is the
equal
yoke muscle here?
innervation to the yoke muscles. Medial rectus, ma'am,
Herring's
of the
rectus
right eye.
is responsible for this secondary deviation more than primary.
Law of equal innervation, ma'am, to the yoke muscles.
I think someone is asking a question.
No, ma'am.
No, no one. Okay,
No, ma'am.
right. So what do you call the medial rectus muscle? Here, the left lateral rectus is involved. What is the name given to the medial rectus? And the opposite lateral rectus, what do you call? What are the changes which occur in that? You are having a left lateral rectus palsy.
Yes, ma'am.
What changes can occur in the other muscles? The yoke muscle and the ipsilateral antagonist and the contralateral antagonist. What are the changes which can occur?
In the yoke muscle, overaction of the medial rectus can occur in the opposite eye.
Okay. Ipsilateral antagonist?
Ipsilateral antagonist, unopposed action of the ipsilateral antagonist can occur.
So what can happen? You said you
So
have done the
deviation
forced
towards-
reduction test.
Yes,
1
ma'am.
minute. You have done a forced reduction and a forced generation. Is it
Yes,
not?
ma'am.
Why
Yes,
did
ma'am.
you do that?
To rule out any restrictive causes in the medial rectus of
Only
the same antagonist,
that's what
ipsilateral
happens.
antagonist.
That's what
Yes.
happens. That is why you have done a forced generation to rule
Yes,
out
ma'am.
contraction of the medial rectus.
Medial
Which can
rectus.
happen. What can happen to the contralateral antagonist? What is the contralateral antagonist to this?
Contralateral antagonist is lateral rectus
Of
right eye.
the right eye. Right?
Yes, ma'am.
Okay. Now, horizontal diplopia, you told, is it not?
Yes, ma'am.
Is it crossed or uncrossed?
It is uncrossed, ma'am.
What other conditions? Which muscles involved produce a uncrossed diplopia? Suppose you are given a diplopia charting, you see an uncrossed diplopia. What are the other muscles which can produce an uncrossed diplopia? Paralysis of which muscles can produce?
I'm not sure, ma'am. I'll refer it, ma'am.
No, there is no need to refer. Obliques.
Obliques.
Is it not? Superior and inferior oblique.
Yes.
Because they are abductors. Is it not? The tertiary action
Yes,
of all the
ma'am.
obliques is
Tertiary
an abduction.
abduction.
So when they are failed, the eye is going into an adduction, that is ESO.
ESO.
I mean, and you have an uncrossed diplopia. Is it not?
Yes, ma'am.
Okay. Suppose this patient doesn't present with diplopia. What do you think of? What are the causes? The patient is there. You
Yes,
have
ma'am.
not mentioned about a compensatory head posture. Did you mention?
Yes, ma'am. There was slight head turned towards the left side. Ma'am.
Left side. Sorry, I missed
Yes,
it.
ma'am.
I
Yes.
missed it. Suppose the patient doesn't complain of diplopia.
Abnormal retinal correspondence.
Any other thing?
Due to compensatory head turn or tilt.
Yes, yes. The compensatory head posture usually that is
Resolves the
diplopia.
Yes.
Now, hypertension, sixth nerve palsy. You said something in the MRI, there is something in the cavernous sinus. Is it not?
Yes, yes, ma'am.
He is a diabetic. And you say
Not a known diabetic, ma'am. He
not
is
a known diabetic, but
yes, ma'am.
HbA1c is more. Is
Yes,
it
ma'am.
not? What
Yes.
else do you think of in the differential diagnosis other than microvasculopathy? Etiology.
Secondary to meningitis or granulomatous inflammation, according to the MRI, we could suggest it, ma'am.
Which,
So
what
we can
granulomatous inflammation do you think?
Tolosa Hunt syndrome,
No. Tolosa Hunt, what will happen?
ophthalmoplegia, and
Yeah, you are not having that, is it?
yes, ma'am. Yes.
Yeah. So because the cavernous sinus is also involved, I think you should rule out a fungal pathology in this case.
Okay.
Fungal pathology is one thing because he is a de novo diabetic, young patient. So
Yes.
presenting with a 6th nerve palsy, you should not miss a fungal pathology. So you
Yes.
can talk to your radiologist and see that if there is any fungal pathology there and
Okay.
to rule out on MRI.
Okay.
Right? Now, what do
Yes.
you plan for this patient now?
Initially,
He
we
complains of
consider,
diplopia, is it not?
yes, ma'am.
What do
If
you
it,
plan?
we can patch the eye, the deviated eye, ma'am, temporarily, and we can wait for its own resolvement, spontaneous resolution.
Hmm.
Every 2 months we'll be checking, ma'am. Even if after 6 months there is no resolution, we can plan for surgery or other. And temporarily we can give prisms for correction, ma'am.
When do you advise prisms? What is the amount of deviation?
18
30
prism
degrees.
diopters, ma'am.
18?
30 degrees. Prism
30 degrees.
diopters on, yes, ma'am, 30 degrees each.
30 degrees. Do you give prisms when the patient has 30 degrees of deviation? And what will happen if you give? What is the
Sure.
purpose of giving a prism here?
To prevent the diplopia, ma'am.
Yeah, in which field? In which field? The central field, is it not?
Yes.
No. So when you give high prisms, what will happen? There will be always an optical blur.
Yes.
And high deviations, you usually don't give prisms. What is the other alternative that is available other than prisms?
Covering the eye temporarily,
Other than
patching.
a young patient may not agree to all those things. Do you have any other alternative? What is chemodenervation?
Chemodenervation with botulinum toxin. We paralyze the medial rectus, so the opposing action is stopped, ma'am. So
Can
the
you try that?
deviation.
Can you try that in this patient?
Yes.
Hmm?
Yes, ma'am.
You can always try. Does it not?
Yes.
You can give a
Yes.
try.
Yes.
Rajesh Garu, anyone want to ask? Let them ask.
I want
Yeah.
to ask you a question, madam.
Yeah.
Yes.
How long will this chemodenervation, how long is it effective?
3 to
8
4
weeks.
months.
8 weeks. 8 weeks to 12 weeks, it will be effective. By that time, this recovers, particularly in older patients. But because this is an young patient, I don't think you have to always exclude something in the brain, MRI of the brain, you have to again see. And because the cavernous sinus is also involved, I think the recovery in this patient may not be as good as in an older patient.
How long can we wait for the recovery? What is the usual protocol of how long can we, 6 to 8 weeks or beyond
6
that?
months, sir.
6 months for an
Generally,
older one. For the young patient, I think you don't wait and you have to see whether there is a progression of this 6th nerve palsy and you have to think of other causes. That's why I told there may be a fungal etiology or because a granulomatous lesion, you should also think of tuberculosis as one of the causes.
Okay.
CT test done for this patient?
no, ma'am.
No. I think you should think of either fungal because he's a diabetic or tuberculosis as the etiology.
Okay.
Any questions, Dr. Danya?
Yeah, Dr. Preeti, here you
Yes.
said the age of the patient is 38 years, yes?
Yes, ma'am.
So normally, when do you suspect, at what age do you suspect this microvascular pathologies for this nerve palsies?
Most commonly above 50.
Above 50. So like Dr. Sandhya ma'am was saying, because the age is less than 50, definitely you should be looking into some other pathology.
Yes,
So
ma'am.
common in less than 50, what could be the other pathologies?
Trauma, trauma or increased intracranial pressure, ma'am, due to meningitis. Uh, any cavernous sinus etiologies, ma'am. Any aneurysms.
Yeah, cavernous sinus etiologies most often will involve other cranial nerves also, isn't it?
Yes.
But there is a chance that only sixth nerve also can be affected in a cavernous sinus pathology. Why? Isolated sixth nerve palsy can also be seen in a cavernous sinus pathology.
Mm.
Because that is the only unprotected nerve which passes along the lateral wall of the cavernous sinus. Okay.
Yes.
So isolated sixth nerve palsy is still possible in a cavernous sinus condition, not always required to have other cranial nerve pathologies. Over a period of time, other cranial nerves also might get affected. So initially, it can only be sixth nerve.
Sixth.
Okay.
Okay.
Sixth,
And
okay.
in cases of this cavernous sinus, if it is progressing, if it's not subsiding, should always look for the lateral rectus palsy in the other eye also. That is the first sign which indicates that the cavernous sinus condition is progressing.
Yes. Preeti, can you just tell me the difference between a concomitant and incomitant squint?
Concomitant squint is a non-paralytic, ma'am. It is due to amblyopia most commonly, and the primary deviation and the secondary deviation will be equal, ma'am. In incomitant, the secondary deviation and primary won't be equal. The secondary is greater than primary, and incomitant is due to paralytic causes, due to nerve palsy most commonly, and
Common symptom, what you would see?
diplopia, ma'am, in nerve palsy most commonly.
In concomitant squints, you will see diplopia. Why not
Yes.
diplopia in concomitant?
One of the eye is not using due to amblyopia.
Not
He
exactly.
suppresses.
You can have 6/6 vision and still have a concomitant squint. Childhood strabismus, children coming to you, children will still be having good vision but having concomitant squint, right?
Yes.
So still they don't have diplopia. Any reason?
I'm not sure.
Suppression? What about suppression happening in the brain?
Yes.
It has
Yes, ma'am.
happened very early itself in the life. Suppression
Yes.
has happened in the brain. That's the reason why paralytic squint will have diplopia, because it has happened suddenly. Okay,
Yes, ma'am.
not given it enough time for the suppression to happen. But if the same paralytic squint is persisting for a longer period of time, then suppression will start. Diplopia will
Yes, ma'am.
slowly regress. The other question I wanted to ask is, even if a paralytic, sudden onset paralytic patient does not complain of diplopia, I think this question already Sandhya ma'am asked. Any other thing you want to suggest? Sudden onset paralytic squint, patient does not complain of diplopia. The patient's attender got the patient to you because they noticed the eye has moved to one side. Patient doesn't.
Due to abnormal retinal correspondence, or due to head turn.
Any other thing? Diplopia is possible if there is vision in both the eyes, right?
Yes, ma'am.
Or by any chance that particular eye is amblyopic, or that particular eye has a mature cataract in it, will the patient complain of diplopia?
No, ma'am.
And the patient, if after operation, you see a mature
He'll
cataract,
complain.
you
Yes.
operate, then
He'll complain of diplopia.
and suddenly diplopia. So diplopia is possible only if the patient has a good vision in both the eyes. Okay.
Yes.
Only then suddenly will call diplopia. So you said infranuclear level. Why particularly you mentioned infranuclear level?
Most commonly, the isolated palsies most commonly occur in the infranuclear level, ma'am. At the
Yes.
nucleus and supranuclear, most commonly other associated nerve palsies may also be there, ma'am. Most common infranuclear isolated.
Yeah. And infranuclear also, particularly at what level can you call that?
Vesicular most common, ma'am.
If it is a microvascular pathology you are looking into. If you are
Microvascular, it's most commonly at the cavernous level.
It can happen at any level. Microvascular can happen at vesicular level also, because diabetes or hypertension, you are just having a patchy areas of damage, right? It can happen at
Yes,
any level.
yes.
Okay. So if you're not looking at any of these pathologies, any of this orbital related or ocular related pathologies, but still have sudden onset diplopia patients coming to you, what other systemic conditions you should be thinking of other than your ocular pathology,
Thyroid
most
myopathies,
right? Thyroid myopathies and
myasthenia gravis.
myasthenia gravis. Good.
Other DDs, Duane's or Mobius, Duane's type 1 or Mobius
Type 1.
syndromes.
Type 1, you should be thinking of isolated rectus palsy. Good. That's all, sir. I think good presentation.
Very good, very good. Dr. Nasima, Nasimara, any more questions from you? You tutored, you mentored your Dr. Preeti very well. Why is Dr. Preeti hiding behind a P? Why is she not? Yeah, come on, show yourself up. You have done a good presentation.
Thank you.
Good. Dr. Preeti and Dr. Priyanka done a real. I think they should done a real good job. Being first year students, first year PG students, right, madam? Sanjay, madam, what do you say?
Yeah, very good, rather. And I want to ask one more question, right?
Yes, madam. Go ahead.
What is diplopia and what is confusion?
Confusion is the state I am in.
Everybody is in.
Diplopia, Dr. Preeti will tell.
In diplopia, on fovea, 2 different images will be forming, ma'am. In confusion on fovea, there will be 2 different images. I'm not sure.
You are not sure.
What are the differences?
Right. You said it is an infranuclear, is it not?
Yes, ma'am.
Infranuclear sixth nerve. Suppose I say it is a nuclear. What else you want to see?
In nuclear,
And what is the complaint of the patient?
Conjugate movements will be lost, ma'am, and it can be associated with facial nerve palsy also due to involvement of
Nuclear
facial
level?
collections. Yes.
Nuclear level?
Yes.
A sixth nerve palsy at the nuclear level. What is INO?
Internuclear ophthalmoplegia.
That's what happens, is it not?
Yes, ma'am.
When the vasculus is involved, you have a seventh nerve.
Yes.
When only the nucleus is involved, you are going to have a INO. Can you tell me about INO, something about internuclear ophthalmoplegia? Anterior.
When the medial longitudinal fasciculus is damaged, the innervation of one side medial rectus and the opposite side lateral rectus is affected. So the conjugate movements are affected now.
Yes. What about convergence?
Convergence is also lost.
Which time? Anterior or posterior?
I'm not sure.
You are not sure. Fine. Last question.
Yes.
When there is a cavernous sinus pathology, okay, and sixth nerve only is involved, what other thing do we expect the patient will have? Not the wall is involved. No wall of the sinus is involved. It is the sinus itself which is involved, which is involving the sixth cranial nerve. What other sign do we look for? Which structure is immediately in relationship with the sixth nerve in the sinus?
Internal carotid artery, ma'am.
So what will it have? Internal carotid artery? What will be there surrounding that?
Plexus, sympathetic plexus, ma'am.
So what will you see?
Horner syndrome.
That's
Horner's.
Good, very good. Right, sir? Rajesh garu.
Sanjay madam.
Very good.
Sanjay madam, నేను రామన్ గారిని మాట్లాడుతున్నాను.
సార్ చెప్పండి. గుడ్ ఈవినింగ్.
ఇవాళ చాలా ఆనందంగా ఉంది నాకు, సంతోషంగా. ఎందుకంటే ఎండి రాసేటప్పుడు మీలాంటి వాళ్ళు ఎగ్జామినర్ గా రాలేదు. అప్పుడు మాకు ప్రేమ్ ప్రకాష్ అని ఒక ఆయన ఉండేవాడు, ప్రొఫెసర్ విమలా మీనన్ ఉండేది. వాళ్ళు గుర్తొచ్చారు ఇవాళ.
సార్ రాజేష్ గారికి చెప్తే నెక్స్ట్ టైం నుంచి నన్ను పిలవడు రాజేష్. ఇంట్లో చాలని చెప్తాడు.
లేదు మేడం, you're always welcome.
No, madam. We want you, madam. Always we want your questions, madam. That will be good for our PGs. Thank you so much for.
This is very, very useful for all the postgraduates.
Yes, madam.
When they get a case like this, they just have to go through, they just have to recollect this discussion. They'll get all the answers.
Yeah.
Excellent,
One thing,
Thank you
madam,
very
one thing, you have to pose questions. That's all.
Yes, madam.
We need our PGs also. We request all PGs to come forward and present in coming days.
Okay, just a thought came into my mind. Dr. Priyanka and Dr. Preeti, this particular webinar is there in YouTube. Go through the YouTube, compile all the questions that all our examiners have asked, and we can publish these questions in our journal, like short cases questions. We can do that.
Yes, sir.
Sure.
Yes, we should.
Sure,
So
sir,
Dr.
we'll do
Priyanka
that.
and Dr.
Sure.
Preeti,
Yes,
Sure,
sir.
sir.
review the YouTube link, YouTube video of this webinar, and
Yes,
compile
sir.
all the questions. That will be useful. We'll publish it for all the postgraduates. It will be useful for all the postgraduates.
Yes.
Sure.
Yes, sir. Yes, sure.
Ravi Garu, anything else?
Nothing. You can give concluded words.
Yeah. Inken chepagala, thanks Tapa. This is we have. I think I should say we had a good start, because this is the first short cases webinar by APOS ERC, and case 1 and case 2 we had excellent PG students who have presented, and double excellent examiners who have really grilled, and half the questions I didn't know. I should be honest about that.
Yeah.
Our president also has told us he is very happy not to have Dr. Sanjay as examiner. But we will have Dr. Sanjay as examiner in all the webinars,
sessions.
in all the sessions. So we can conclude this. Thank you very much, and I wish that all the postgraduates will participate in more numbers in the future short cases webinar, and we are going to have the short cases webinar every last Friday of each month, every month. So I want all the postgraduates who are watching this to spread this message, and then come up with short cases. Go to your mentors, go to your professors, present those cases to them, and then send those cases to us. There is a email that I have already shared in all the groups. Please present your cases so that we'll review those cases, and then we can include you in this short cases webinar, which will happen every month, last Friday. See you all next last Friday. I think that will be 26th of December. Thank you very much for participating, and a special thanks to our examiners. Thank you very much.
Okay.
Thank you.
Thank you, Dr. Rajesh.
Thank you, sir.
Thank you very
Thank
much,
you.
and good night, everyone.
Good night,
Thank you,
everybody.
madam.
Thank you very
Thank
much.
you.
Thank you, ma'am.
Thank you.
Good night, ma'am.
Thank you, madam.
Thank you,
Hi,
sir.
Razu.
Madam, good evening, madam. So Rajesh sir, Sandhya madam, good evening, madam.
Good evening. Good
And I really thank Rajesh sir and you also. Like it was like I was actually sitting back in my examination now 8 years back, feeling tense. Like okay, now I don't know this. I was just thinking, like sir said, most of the questions even we also like we forgot it. But thank you, madam. Like this was a very enlightening session, and I'm sure whoever PGs have actually seen this today, they'll be surely inspired, and they'll probably compete to present here. And all the questions what you have asked, madam, I'm sure these will be the questions standardly that will be asked for these short cases. So once if they really see this session and this presentation, I'm sure they are going to be benefited a lot, and all the questions will definitely be repeated, I'm sure, for all the exams also. Thank you, madam. That was very nice, and Dhanya and was very nice also. Thank you, Sandhya madam, and thank you, Rajesh sir. Thank you for making us part of this beautiful session. Thank you, madam.
Thank
Good
you
night,
all.
everyone.
Good night, everybody.
Thank you.
Thank you,
Thank you,
Sandhya
Sandhya ma'am. Thank you, Dr. Dhanya.
Thank you,
for
Sanjay madam.
accepting.
Thank you, all
Thank you.
ARC members, sir.
Thank you.
Thank you, Rajesh sir, for this platform, giving for our PGs for the first time. And sure, madam, we'll make it much more beneficial for the PGs, madam, in coming days. Thank you for accepting. Thank you. Bye.
Okay, madam.
Thank you,
Good night to all.
Good night, sir.
Good night. Good night.
Download the Google Home app on a phone or